realistically, what are the challenges because of this delayed pregnancy?
There may be a slightly higher chance of getting gestational diabetes, which is basically diabetes during pregnancy, or hypertension in pregnancy.
How the egg reserves decline? Like it's a peak at what age and it declines?
So it will be peak at up to 25 to 28 would be peak. 32 to 35 it's declining.
What is not a good reproductive system looks like?
Women who may not have period, they have very irregular period, maybe bleed once in 3 or 4 months, or they have very heavy bleeding, or they have extremely painful periods.
Kitna percentage of between men and women comes out having fertility issues?
Like 50% is because of male infertility, and obviously 50-60% is because of the woman.
So at what point you should freeze your egg?
I would say do it now. Don't wait till you're 28 or 30.
So what is genetic testing on an embryo?
So we check for aneuploidies. Aneuploidies are numerical problems like trisomies or deletions, etc. That is basically embryo testing.
What are the biggest warning signs during pregnancy a woman should absolutely not ignore?
So in the first trimester, of course, any bleeding that happens, heavy bleeding, abdominal pain, extreme vomiting, nausea. Later in pregnancy, definitely any reduced fetal movements or leaking, like sudden blurring of vision, very severe headaches. These are signs she should not ignore.
Let's say a healthy woman got pregnant. During pregnancy, she turned into a high-risk pregnancy individual by either getting diabetic, asthmatic, high blood pressure. My question is that get transition or get to the baby also?
No. So there is no in utero transfer of, say, the diabetes or the hypertension to the baby.
Especially in the case of blindness, baby gets blind only after a certain age.
Checking of vision should also happen at a regular interval for all babies.
Women during sneezing and coughing, they experience bladder leakage. Why does this happen and how it can be treated?
These pelvic floor muscles, they get weakened. Because they get stretched, they get weakened.
Women go through infections as well, right? Because of the stitches going wrong and all.
Just in a tub, you can put warm water and just sit in that for some time, maybe twice a day, which will help the swelling in that area.
What is PMOS or PCOS and what exactly going on inside a woman's body?
Basically, disrupt the ovarian and the pituitary hormones.
But they can still conceive with the right treatment.
Absolutely.
Do women that usually comes to you, do they know that they have fibroids? Or
they may not know. You will not believe it. One was 21 centimeters and the patient was an educated girl and she had a uterus which was equivalent to a 7 months pregnancy, but she was just not aware. She thought she was gaining weight.
Hi guys, welcome back to another episode of Raw Reflections. Today we have Dr. Amrita Tandon. She is a laparoscopic surgeon, cosmetic gynecologist and an IVF specialist. She is joining us to let us cut through the confusion and talk medical facts around fertility planning, topics women usually hesitate to talk about. So let's dive in right away. Hello Dr. Amrita, thank you so much for joining us. We are so looking forward for this conversation, personally me, because I'm still learning about this topic and I have so many questions understanding the IVF, what goes in a woman's body in and out. As a partner, I want to know it. So I'm really glad that you are able to join us.
Thank you so much for having me. It's actually my pleasure and it's really nice to be out here.
So first of all, what does a healthy reproductive system looks like?
I mean, when we're talking about women, right? So basically regular menstrual cycles, something which is not too heavy or too painful, predictable ovulation which happens every month, and your anatomical, like your ovaries, uterus, everything is normal in place. That would typically be for the women. And for men, it would be a normal semen analysis report that we, when we check.
Do you think sleep, stress, and diet plays a major part in the health of reproductive system?
Absolutely. I think sleep, stress, exercise, lifestyle, diet, these have a huge impact on, maintaining a healthy reproductive system for women and men, but especially for women. So sleep, if, there is disruption of sleep, this can actually cause a lot of hormonal imbalances and it can disrupt your menstrual cycles. Stress, chronic stress can lead to elevated cortisol levels, which again will disrupt your menstrual cycles. what you eat is extremely important, right? Nutrition is important. Maintaining a healthy weight is important. So, uh, very underweight women or overweight women will have a disruption of menstrual cycles, and typically they don't have a very healthy reproductive system. Even exercise. So all these play a very, very important role in maintaining your you know good reproductive system.
What does not a good reproductive system looks like?
Women who may not have period, they have very irregular periods, like they maybe bleed once in 3 or 4 months, and uh, or they have very heavy bleeding, very frequent cycles, like every 15 days they may be bleeding for prolonged days, or they have extremely painful periods. These are typically, signs that something is amiss, and probably you need to visit your gynac and get yourself checked. Because a lot of women, they just feel that, okay, this is normal. This, heavy bleeding or painful periods are a part of what is normal, and they don't approach a doctor or a professional for help, which is kind of wrong, because then that postpones the uh, you know diagnosis. Basically, when we see a patient who has all these symptoms, we can more often than not come to a conclusion as to why this is happening. Like, for example, irregular periods, if they bleed every 3-4 months, they may have PCOS, which is the most common thing.
क्या मेल के लिए सिर्फ एक ही चेकलिस्ट है दैट गेटिंग अ सीमेन एनालिसिस डन, बट वुमेन, मुझे आपके आंसर से ऐसा लगा कि देयर इज अ लॉन्ग लिस्ट ऑफ चेकलिस्ट फॉर वुमेन रिप्रोडक्टिव हेल्थ एज कंपेयर टू men.
Yeah, so male के लिए the main one is the semen analysis, because that basically the semen parameters will tell us about the sperm count, the motility, the morphology of the sperm, and that is important. But having said that, we also check uh, basic blood levels in the male, right? Like we do a CBC, that is a complete blood count, to make sure that the partner is not anemic. We do a blood sugar test, HbA1c, because diabetes in men will also increase their risk of having semen abnormalities or low sperm counts, low motility, which is very common. So, in fact, when a couple comes to us, we see the couple as a whole. We treat them as a whole and not just the female. We even check the weight and blood pressure of the husband, because sometimes on that routine checkup we find out that the husband has hypertension, or is diabetic, and that comes as a surprise to them. But it needs to be treated, because when we're treating fertility, the overall health of the couple is also extremely important. So when we optimize that, we have better results.
कितना percentage of between men and women comes out having fertility issues when it comes to men and women?
Like 50% is because of male infertility, and obviously 50-60% is because of the woman. And more often than not, it is both together, so it's like a combined cause of subfertility.
Yeah, so there could be both also.
Both also, very commonly, very, very commonly, we have the woman having, say, a low AMH, and the male also having a low sperm count or a low motility. So it depends, but yeah,
मोस्टली लाइफस्टाइल में ऐसा कहा जाता है कि स्मोकिंग और ड्रिंकिंग इज द
it's
हाईली
complete
इन्फ्लेमेटरी थिंग और
no.
ये रिप्रोडक्टिव हेल्थ के लिए अच्छा नहीं है. बट among our friends we have saw couples who don't drink and smoke, still they have reproductive health issues. May I ask why it is?
Yeah, so see, it is not reproduction is not typically, I mean, it is not only limited to how healthy your lifestyle is. Unfortunately, there is a lot of other factors that may impact it, like genetic problems, right? Like a seemingly normal couple at say 30, and the wife, she may have a low AMH or a low egg count, with no prior history or any. It may just come up as a surprise for them. So yes, being healthy, avoiding smoking and alcohol consumption is extremely important in the long run as an overall health, thing that one must obviously incorporate in your life, but it does not uh, guarantee you a baby. Yeah, I would just put it as bluntly as that. But yes, if a couple comes to us and the husband or the wife, either of them are consuming alcohol or smoking, we do tell them that this needs to be stopped because basically smoking can destroy it can affect the DNA of the gametes, which is the egg and the sperm, right? So there is oxidative stress, oxidative damage to the DNA, which happens to the sperm and the egg, which is why the quality of the eggs and the sperms really deteriorate. And we see that even when they undergo IVF, we have low fertilization rates, bad quality embryos, recurrent implantation failures. So these are things that would have been avoided had they, have stopped smoking or
If they do drink and smoke, how long before they start trying they should stop it?
I would say 3 months. Yeah, I would say that would be an ideal thing. But say if they came to me at 35 and they do drink and smoke, I would just tell them that you stop from now on and you start trying. Because when they start trying, they may not conceive in the very first month of trying. It may take about 3 to 4 months for them to actually conceive naturally. And even when we do some fertility treatments, say if they're of a younger age and everything else is apparently healthy and they've just come for a prenatal check or a pregnancy planning sort of way, we tell them that you can start trying. You give up all your, smoking alcohol, you can stop that. We put them on some prenatal vitamins, especially folic acid, and we even incorporate antioxidants for them, like coenzyme Q, because these are known to reverse the free radical injury that can happen to the gametes. So, maybe 2 to 3 months of antioxidants plus prenatal vitamins, plus optimizing your overall lifestyle, exercise maybe 3 times a week, have a normal healthy diet, come into a good normal weight bracket, and that actually you know helps them conceive faster.
More and more women's, for good reasons, they are planning the pregnancy at a later stage in life. Realistically, what are the challenges because of this delayed pregnancy?
Yes, we do see a lot of women actually planning late pregnancies, and that could be because of whatever career, personal reasons, etc. But there may be a slightly higher chance of getting gestational diabetes, which is basically diabetes during pregnancy, or um, hypertension in pregnancy, which is a high blood pressure during pregnancy. And advanced maternal age is known to increase the risk for these two, especially these two. And what happens with hypertension and diabetes is that it is it's a strain on the mother's body, right? And that can even affect the fetal growth. It can cause fetal growth restrictions, small babies, or in diabetes there may be large for gestational babies, and even complications because of this hypertension which are very severe, like eclampsia, which is basically seizures during pregnancy. It's if it gets very, very complicated, that pregnancy induced hypertension, if unchecked, it can actually go to a stage called eclampsia, wherein the woman might have seizures. And then all these obviously increase the risk of, it becomes a very high risk pregnancy. But yes, it's not to scare women, right? We are seeing a lot of healthy uh, pregnancies in the late 30s and early 40s, and with good medical support, with frequent assessments, frequent sonographies, checking the mother, the pregnant patient periodically, making sure that everything is in check. Most of them are uncomplicated.
So diabetes, hypertension, and blood pressure, as you mentioned, they might become a reason for planning delayed pregnancy. Might be, but are there chances like a normal healthy woman, once they got pregnant, they get this thing not because of the age, just because you said like sometimes the pregnancy goes high risk pregnancy.
So definitely, anyone who is in fact, even younger women can get gestational diabetes. Uh, Very young women, in fact, who get pregnant very early, like less than 20 years of age, uh, are at a higher risk for getting hypertension during pregnancy than, it's just something that studies have told us, and that's the data that is available and from experience. Um, s- Even patients who have PCOS, like prolonged PCOS, they already have insulin resistance. So they may also have a higher risk of getting diabetes during pregnancy or hypertension, because these are all metabolic problems, and PCOS, as we know, is a metabolic disease. So these women, or obese women, so women who are overweight, right, or not healthy to begin with, may at a younger age also are at a higher risk for all these problems.
So when somebody is your candidate for a high risk pregnancy, for just because of the reasons like, okay, it happens, how as a doctor your treatment changes because of that?
Slightly more frequent visits, probably more frequent scans are offered to the patient, because we have to check the mother's parameters. We do her blood checks routinely, regularly, check her weight, blood pressure, etc. And for the fetus, just to check that the baby is growing well, we may need to do multiple sonographies and, maybe a slightly more advanced tests, like to check the Doppler or the blood flow which is going to the baby, because that is something that we're afraid of, or we want to make sure that the baby is getting enough blood. So ultrasound with Doppler assessment can tell us whether the baby is getting enough blood and nourishment as it should be. So, basis that, we can time the delivery also.
So, if a couple is not planning for a baby immediately and wants to have a late um, baby, what are the fertility checks they should start doing it from now or eventually?
Any couple who wishes to conceive in the future, or even if they don't, but they probably don't know if they want to have a baby or not, the wife should definitely get her ultrasound done, right? An AMH test, which is basically anti-Mullerian hormone, which can tell us the egg reserve, right? Because we know, I'm sure like all of us have heard so much about AMH and the ovarian reserve, because basically what happens is that women are born with a fixed number of eggs, right? And that is determined at birth. That can't be changed. Like you were asking about healthy lifestyle, why are women, even if they're healthy, why do they have fertility issues? So this is a genetically predetermined thing which cannot be changed or altered. So uh, definitely that should be checked, an AMH, a thyroid evaluation, because a lot of women might turn out to be hypothyroid, or a prolactin level may be raised, and that can be a cause of fertility. Basically, being proactive and having the knowledge of, uh, say, if there are issues that can be dealt with, it's always better to know prior. And for the male, the semen analysis, and like I said, the sugar test, CBC. Similarly, for the woman also, I would do a blood sugar test and a CBC, and viral markers for both. Like,
So, at what point you should freeze your egg? Like, suppose you are now 25 and you're planning to have your baby at the age of 35. So, should you immediately freeze your egg or?
I would say, if a woman comes to me at 25 and she's sure that she wants to have a baby after 35, I would say do it now. Don't wait till you're 28 or 30. Let that ovarian reserve go lower. chances of getting good quality eggs reduces as you age. So the earlier done, the better, because you will get a higher number of eggs and you will get a higher quality of eggs. Just to put things into perspective, when you freeze your eggs, you need at least 12 to 15 good eggs to give you one live birth, right? So at say a 25, 26-year-old, in one cycle, we might be able to get those many because she has a good ovarian reserve and everything is normal.
What is ovarian reserve? Good ovarian reserve.
Correct. So, see, ovarian reserve is basically determined by mainly two factors. One is doing the ultrasound, wherein we see the antral follicle count that is present in both the ovaries. So, there are two ovaries, right? We measure the ovaries, we check the volume of the ovaries, and we check how many small follicles. These antral follicles are typically small follicles ranging from 2 to 10 millimeters in diameter, which will basically become a dominant follicle and release your egg in that particular cycle. So, what we do is we do a day 2 during the periods, day 2 or day 3 baseline scan, wherein we count the number of follicles that are there, that are present, that can possibly be stimulated when we do an IVF cycle. And also an AMH test. Like I said, AMH is a blood test that is done and it can be done anytime during the period cycle. It's regardless of the day of the period. What we can also do is do a day 2 FSH, that is the follicle stimulating hormone. Again, another hormonal test which will determine the ovarian reserve for this. Definitely, if they are very sure of their plans of, delaying pregnancy for another 10 years, I would say freeze your eggs. You can freeze your embryos also. So I would give them that option, because if they are married, say if this patient comes and she's sure of a partner or she's married, then I would give her the option to freeze her embryos, because basically what happens is when you retrieve, the difference between egg freezing and embryo freezing is, egg freezing is we stimulate the ovaries, we retrieve the eggs and we store them or we freeze them. With embryos, we retrieve the eggs, we fertilize them with this. We put in
With the partner's sperm.
with the partner's sperm, and then we grow these embryos till day 5 or the blastocyst. So we have a better assessment of the quality of the embryos, of the number of eggs that can get fertilized.
At one point, how many embryos can you freeze?
We freeze all the embryos that we get. Now it depends on whether we are testing them for a genetic abnormality or not. So that is basically by doing a PGTA. That is also an option that can be given to couples, especially if they are above 35 and if they have a risk of any genetic abnormality, or they've had repeated implantation failures or negative, like negative IVF cycles. They've not conceived with multiple IVF cycles. So whatever embryos we form, day 5, whether they are 6, 8, 10, we freeze all of them. We freeze them in different straws. So, for example, we may choose to freeze them as a single embryo or as 2 embryos in one straw, depending on what the patient wants. Some patients want a single embryo transfer. They don't want that risk of having a multiple pregnancy. So it's their choice. So if they want a single embryo transfer, we freeze a single in a single straw, and whenever we want to do a transfer, we thaw that and we transfer.
So, how do you decide how many embryo to freeze? Is it like determined by the cost, or it's the same cost?
Typically, it's the same cost. It doesn't change if you have excess number of embryos. The whole point of freezing embryos is to freeze the excess, is to make sure that you have a good number at your disposal for a later date, right? Now, freezing involves a cost. It involves a recurring cost. So, say you were to freeze your embryos at 25 and that IVF clinic says, okay, this is the X amount for the first 2 years. So, every year you'll have to renew, but it's not it's a nominal cost. It's something that, it's very affordable.
Egg freezing and embryo freezing cost is similar or different?
Right now, it is pretty much the same. Anywhere IVF cycle, whether you're doing embryo freezing, egg freezing, it would be about 2.5 to 3.5 lakhs.
For how many years?
For that 1 year or for the first 2 years. Yeah. Some IVF clinics do charge more for more number of embryos. Say there are 20 embryos now. That's of course doesn't happen, everywhere, but it's more often than not there are lesser than 10 number of embryos. But say we do have a very large number, like 15 embryos or something, then they may charge you a little more for that.
And that's absolutely on the patient to decide whether.
That's absolutely on the patient, but the patient can have information about how the quality is. So if the patient chooses, she can choose to only store the good quality, the best quality embryos, because that grading is done when the embryos are frozen. So when they become day 5 or the blastocyst, if you're not doing a PGTA, because a PGTA is expensive, basically genetic testing is expensive.
Please
And
explain, doctor, what is genetics testing on an embryo? This is interesting.
yeah,
And
so basically what is done is there's a laser biopsy that is taken of the trophectoderm, which is the layer of the embryo. Some few cells of the embryo are taken and that is sent to a genetic lab. So we check for aneuploidies. Aneuploidies matlab numerical problems like trisomies or deletions, etc. Okay, so if that is basically embryo testing, and once we and
हम
then
यहाँ पे क्या टेस्ट करके क्या चीज़ पता कर रहे हैं? मतलब when the doctor does it, the embryo testing out of all the embryos जो लिए गए हैं उसके अंदर से
chromosomes come in pairs, right? There are 2 chromosomes per number. So if there are 3 instead of 2, then that is an aneuploidy. Matlab it is abnormal, right? So, and those embryos will either not implant, they may miscarry, or they may go on to give you a baby which is not
Down syndrome.
Down syndrome, right? So that's trisomy 21. So these things can be checked for. And that is why when the risk of these aneuploidies increases when the maternal age is higher, like above 35 and especially above 40. So above 40, so we definitely tell them that you please get the PGTA done, because that will at least improve the chances of a conception.
So it doesn't decide what age you want to get pregnant. If the egg or the embryo is frozen at this,
At an earlier age,
yeah,
then even if you conceive 10 years later, the chances of conception are high when you've frozen your eggs or embryos at a younger age.
So I understand कि women reserve of eggs are limited. If you have to number it, like कितने होते हैं and at how it declines, so women who's watching, they might have knowledge ki what bracket they are in and what they exactly have to do.
So if they were born with X number of eggs, right? Now at puberty, once they start getting their periods,
16 to 18.
slightly
Maybe.
earlier.
Okay, earlier, yeah.
11,
Okay.
12, I would say.
11, 12 to?
Yeah.
Okay.
Right? That's when they start having their periods. Now, every month that they have their period, out of those, what I explained about the antral follicles, out of all those follicles, one follicle ovulates, one egg gets released, and if there is no conception, obviously, then the lining sheds and the girl has her period. But all those other eggs in that cycle, which didn't grow to a dominant follicle or which didn't ovulate, will also undergo, some of them will undergo atresia or they will die. So every month there is a number of eggs that undergo atresia or they die. So imagine the number of months and years that a woman menstruates. Every month her egg count is depleted.
But it's still fixed.
It is fixed.
Okay.
It is
Not
fixed and
unlike
it is
men.
unlike men. So it is also very dependent on the mother's or the genetic history. Meaning, when her mother had her menopause, or what was her mother's fertility at a particular age, whether she had an early menopause, then that girl may be at a risk for depleting ovarian reserve at an earlier age. This is also something that we asked during the history, whether okay, did your mother have menopause at say 50, or did she have an early menopause at 42, which is obviously early, which means that there is some genetic predisposition to having a low ovarian reserve.
So how the decline is, like, if you have to put that in a bracket of years, how the egg reserves decline? Like, it's at peak at what age and it
It is
declines?
so it will be peak at, of course, the say up to 25 to 28 would be peak, right? So 18 to 26 would be absolutely peak. 26 to 32 would be very good fertility again. 32 to 35 it's declining. Beyond 35 it is rapidly
Means
declining.
the number of good eggs are going
Number
down.
and quality are going down.
Now I have another question. When an IVF specialist has a candidate who wants to get pregnant, they put her on hormones injection so she can produce more quality eggs, and which the IVF specialist can retrieve and freeze it. Does that stimulation of producing more eggs is taking the number of eggs out of the total reserve the women have?
Yes. We cannot stimulate what's not there. Correct. So if a 25-year-old patient undergoes IVF, she has a very good AMH. Her AMH is say 5 or 6, which is a normal AMH. And she has at least 10 follicles that we can see on each side, versus a 40-year-old who has an AMH of 0.5, which is of course low. And the antral follicles that we can see are 2, 3. Correct. So in that 25-year-old, we may be able to retrieve 20 eggs. I'm just giving you a number. In that 40-year-old with just 2, 3 antral follicles, we are aiming to stimulate those antral follicles. So we will get only those many number of eggs. IVF will not help improve the egg reserve, if that's what you were asking. IVF can only optimize or increase the chances or the number of eggs that are retrieved per cycle.
During the conversation, you said good quality eggs, and the quality will be not so good at the later stage. What's the difference between a good quality and not so good quality egg?
It's basically the genetic make again, the chromosomal number. So, a good quality egg at 25, the chances of fertilization or forming good quality embryos is higher because that is chromosomally normal. There is no oxidative damage to the DNA that has happened. Whereas in a woman who's older, because of age dependent, decline, the genetic make is poorer, hence the quality. There are certain diseases which may reduce the quality. For example, endometriosis. So, endometriosis may there is chronic inflammation for years together, right, in the ovaries. This might also cause a decline in the egg quality. Typically, we see even younger women with endometriosis, they have an issue with embryo quality. For that matter, even PCOS, because PCOS also is some form of inflammation or chronically elevated estrogen, levels in that woman cause a decline in the eggs. So all these causes can lead to decline in the quality of the eggs.
Are we normalizing freezing egg so much, but unknowingly we are also promoting late pregnancy, which might medically become difficult in future?
I would say if I would counsel the couple, and tell them the real risks involved with uh, conceiving at a late age, like you said, medical complications. Having said that, not all women who conceive at a later age will have a complicated pregnancy. That is one. I mean, a woman who wants to conceive at 35, I would say definitely you want to freeze your eggs at 29. Please go ahead and do it, because at 35, it might be late for her to actually conceive naturally. And that is the kind of, uh, surety or a sort of, I would say, like assurance that she would have that she's frozen her eggs while her egg reserve was still low. I mean, was still good. So,
Yeah.
and so I don't think we are trying to change what is normal. But having said that, I would tell the couple or this girl who wants to delay her pregnancy that even with preserving your fertility, freezing your eggs, it does not guarantee you a baby, right?
Yeah.
It you may undergo you may have to undergo 2-3 cycles of egg freezing to get a good number of eggs. And even after, once you do want to conceive, those eggs have to be thawed. Then your partner's sperms have, like, we need to do an IVF for those. Then we have to grow them to embryos. So there will be a slight attrition. Means some of the eggs may not fertilize, some may not grow to day 5. And then the woman has to obviously undergo an IVF cycle or a frozen embryo transfer cycle to conceive. So if the woman has made up her mind and she has very valid reasons to do so, right? It's a personal choice. So I'm definitely for egg freezing. I would tell that patient, please do it, because down the line, you don't know what your egg reserve would be and how soon it would decline.
Yeah, one follow-up question on the same. While we are talking about the reserve eggs, at the same time, if a male comes to you and has his semen analysis done and it came out right, how it will decline as he age?
Fortunately for men, the decline is not so rapid and it is not so early as it is in women. And hence, that age factor is not so much of a concern. I'm not saying it is not a concern at all, but if I were to compare a 35-year-old woman eggs versus maybe a 48, 50-year-old men sperm would be something I would compare.
What are the biggest warning signs during pregnancy a woman should absolutely not ignore?
Yeah, so I mean, when we're talking about, say, we'll talk trimester wise, right? So, in the first trimester, of course, any bleeding that happens, if it's a little bit of spotting, whether it is a little bit of spotting or whether it is heavy bleeding, abdominal pain, or extreme vomiting, nausea, these things she should definitely get to the attention of her gynecologist. Later in pregnancy, definitely any reduced fetal movements or leaking, right? Like, say, the amniotic sac has burst and she has leakage of like watery fluid, correct? Or she suddenly feels that, or bleeding in late trimester. When we talk about signs of preeclampsia, typically it is a little medical, but these are warning signs like sudden blurring of vision, very severe headaches, or sudden like swelling or edema, which was not there otherwise. Suddenly her face is swollen, her feet are swollen. So these are all warning signs that that particular problem is probably getting more exaggerated or it is worsening. It's a sign of a worsening um, preeclampsia or a hypertension in pregnancy. So these are signs that she should definitely not
Ignore.
ignore. Yeah, these are signs she should not ignore. Even pain at any time during pregnancy, because we have seen that there can be second trimester miscarriages also, where a patient might just go into preterm labor, or early preterm, like early third trimester preterm labor. So if she has contractions at, say, 30 weeks and they're not stopping, they are maybe coming at every 3-4 minute intervals, they are increasing in intensity, they are regular contractions, definitely she should not ignore that, because that may be a sign of a preterm labor, impending labor. And if she reaches the hospital sooner than later, if she doesn't ignore these signs, then there is at least some hope that we might be able to salvage that pregnancy. Otherwise, if it's too delayed, we have to deliver the baby, whatever gestation it is. Like if it's very advanced preterm labor at 30 weeks, we might still have to deliver that baby. And then,
So it says that after you get pregnant, the first trimester, the first 3 months, it's the most difficult or the high risk period, and usually that's why people don't disclose that they are pregnant. Why so? Why the first 3 months are so crucial?
because basically, to put it very simply, the chances of miscarriage are higher in the first 3 months. It's basically, I would say, nature selecting the healthiest embryo, right? If there is a chromosomal abnormality or a genetic abnormality in the embryo, usually these embryos don't grow beyond 6 or 7 weeks. So, the first sonography that we do at 6 weeks, we may not see the heartbeat or the fetal pole. Or sometimes we see the fetal pole, but at a uh, scan which we do 2 weeks later, suddenly that heartbeat goes away. Now it's easier for it's easier for the patients if they haven't disclosed it to everyone else around them to deal with that, because of course dealing with a miscarriage is also not easy. It is a mental, it does have a sort of negative, yeah, traumatic.
But is it the same thing for IVF also, or IVF and normal both the cases? But in IVF, as you said earlier, that you choose the healthiest or the good embryo.
So we don't do PGTA in all the IVF pregnancies. That is one. And IVF pregnancies, because we are giving them hormones to support the pregnancy, right? Typically, what is done is we are giving estrogen and progesterone hormones to support the lining of the uterus. Progesterone, which is given from outside to support the growth of this pregnancy. Whereas in a natural pregnancy, the progesterone is released from the corpus luteum in the ovary. So we don't necessarily need to supplement it from outside. So I would say it is crucial. It's a crucial period for whether it's a natural conception or an IVF conception. First 3 months, uh, I would say just, take all your prenatal vitamins. If your doctor has advised you progesterone or any other form of like injectable, oral, whatever form, that needs to be taken very carefully.
Let's say a healthy woman got pregnant. During pregnancy, she turned into a high risk pregnancy individual by either getting diabetic, asthmatic, high blood pressure. My question is that get transition or get to the baby also?
No. So there is no in utero transfer of, say, the diabetes or the hypertension to the baby, but the growth of the baby might be affected. For example, in a patient who is hypertensive, there may be less blood flow because of. So, in hypertension, what happens is that the blood vessels get constricted, right? They narrow. Constricted means they get narrowed. So, typically in pregnancy, these blood vessels have to become wide or dilated, and hence they allow the flow of oxygen, nutrients to the baby. Now, that might be hampered, and the baby's growth can get restricted. So, the baby might be a low birth weight baby or a growth restricted baby, which is very common with hypertension. Diabetes, once the baby is born, we have to really take care of this newborn. We have to monitor the blood sugars because the baby might be at a risk for having low blood sugar or hypoglycemia. Sometimes these babies need NICU care also for the first few days, just to tide over that initial, important, crucial newborn for early days of birth.
And what about the symptoms once the baby is delivered? Like the women actually the diabetic, asthma, and high blood pressure, will that be reversed?
With gestational diabetes, going forward, 50% of these women might actually end up having type 2 diabetes in the future. It may not be immediately postpartum. Some of them may also continue to have that diabetes. In some cases, it may be reversed. Similarly, with hypertension, also, some might continue to have that high blood pressure, and some, because it was only a pregnancy induced thing, it might go back to normal.
So it's physical, it's cognitive, it's neurological, or all three?
Yeah, it can present in all three ways: cognitive, physical, neurological, everything. Because and like I said, these developmental issues cannot be determined at birth. They will only be determined once the child goes through those stages of development, and then regular pediatrician checks will help the parents know if there is a delay in development, if that delay is within the normal limit, or it is something that needs to be, taken care or addressed sooner than later.
Like some cases, uh, especially in the case of blindness, people only like the baby gets blind only after certain age. So this is also a part of complicated.
Not necessarily, but having said that, blindness, I mean, basically, checking of vision should also happen at a regular interval for all babies. I mean, kids as they grow up, and even hearing. So, hearing is one more thing. In fact, an audiometry to check if the baby can hear normally is done at birth nowadays for all babies. So, it's become a universal screening wherein we check whether the babies are hearing correctly or not. So, eyesight at birth cannot be checked. That can be checked as the kids grow older. But definitely, hearing is something that is checked.
Are women actually prepared mentally for the postpartum phase?
So, I think, like how we were discussing, women prepare throughout their pregnancy. They take all the possible care with their prenatal vitamins, with their increased protein intake throughout pregnancy, regular antenatal checkups, sonographies for the baby. But when the delivery happens, they are not prepared for that sudden hormonal crash that happens, And of course, with that, what is required of them, which is breastfeeding, sleepless nights, the mental load, emotional instability, and the fact that the baby is completely dependent on them for nutrition, should they choose to exclusively breastfeed. So that is something that women are not prepared for, especially first time mothers. So whenever these couples come, I always counsel them that your pregnancy is one thing, but you should also prepare for the first 6 to 8 weeks of postpartum, because they are truly tough. If you feel that being pregnant and carrying a baby till term is tough, what is to come is probably even tougher. And I'm saying that out of my experience. And why my experience? Because I have seen so many pregnant patients. So when I had a twin pregnancy, which was slightly complicated because I had preterm labor at 25, 26 weeks, and I was on bed rest for a good 10 weeks. But throughout pregnancy, I was very aware of everything that was happening with me, and I was sure that, okay, I will cross this thing. But once I gave birth, I was also clueless. I had done so much research about breastfeeding, about pumping, formula, baby sleep, sleep deprivation in the mother, what can happen to like emotional changes, physical changes of postpartum. But you're not prepared. No matter how much you've read, you are just not prepared to, deal with what comes. So having a good support system at home, having help, asking for help. If you feel that you're too emotional, or you have postpartum blues, or you feel depressed, you should ask for help. You should meet a counselor, or you should just talk to your gynac or your family members, and try to take small breaks, and basically, yeah.
After postpartum, often it's so, and I read that women during sneezing and coughing, they experience bladder leakage. Why does this happen, and how it can be treated?
Correct. So basically, what happens during pregnancy and childbirth is that the pelvic floor, right? Pelvic floor is basically a group of muscles and ligaments which help support the uterus, the bladder, and the bowel. Okay. And during pregnancy and childbirth, these pelvic floor muscles, they get weakened because they get stretched, they get weakened. And especially during vaginal deliveries or repeated vaginal deliveries, the pelvic floor can really get weak. And because of that, there may be what you basically spoke of is called stress urinary incontinence. Means whenever there is an increase in abdominal pressure, when you cough or sneeze or laugh or jump, there's a sudden leakage of urine. A lot of women feel that this is normal. ये तो सबको होता है. But that's not true. Even if it is very common, it is a significant complaint which can be treated. Um, Treatment basically involves pelvic floor physiotherapy, right? Kegels exercises, yeah. But let's be frank, it's very difficult to do Kegels exercises enough for them to be that effective. So nowadays, in fact, there is a branch of gynecology called functional gynecology or cosmetic gynecology, but I would say it's more functional, where there are devices which are non invasive, means we don't need to actually operate on this woman, by which we can improve the strength of the pelvic floor. There, there are two ways. One is there is a chair that is available. The patient has to do multiple sittings on the chair, and that causes contraction of the pelvic floor, just like how Kegels would, cause. And there's also V tone, which is what we have basically. It's an EMS, electromagnetic stimulation, which causes involuntary contractions of the pelvic floor muscles, and it retrains this pelvic floor to kind of contract when there is a rise in abdominal pressure and prevent that leak. And of course, over time, it strengthens it. So women should know that postpartum, there are various options that are available to regain or recover from all these functional issues that they have
So,
because of childbirth.
bladder leakage is only associated with multiple pregnancies, or it can happen with single pregnancy
It
also?
can happen with single pregnancies also. It may just happen with after the first pregnancy also. It can even happen in a patient who's undergone a C-section.
So, when you're talking about pelvic floor muscles and exercises associated with it, vaginal rejuvenation, is it similar to that or it's completely different?
Yeah, vaginal rejuvenation is also a part of that entire gamut of things that we can offer for functional well-being, because finally, along with the pelvic floor, the vagina may also become lax, or the woman might feel that it's loose in very simple terms, or she may feel dryness in that area, or she may have reduced sensation. These are very, very common things. Women may not actually come up and speak about them, but it does happen, especially postpartum. And these things can be treated with either lubrication or creams, basically hyaluronic acid gels, or even non-invasive treatments like radio frequency and laser therapy, which will help improve the epithelium of that vagina, which will help. So, just like how we do radio frequency for the skin, right? Face skin, we do microneedling, radio frequency to have that tightness and for anti aging. So, the vagina is also an organ. It has collagen, it has elastin, which gets depleted with age and because of childbirth. So, that can be regained by offering these kind of treatments to improve the function.
It's completely non-invasive, non-surgical procedures.
So, to some extent, if it is not very severe, in about, I would say, 70 to 80% of these patients, we can treat them with non invasive, machine based or device based, energy based devices, which would be radio frequency, MNRF, or it could be laser. Whereas, and the pelvic floor strengthening, which I spoke about, the chair and the EMS. But if there is a very severe urinary incontinence, right, and we've done multiple sessions of non-invasive, then we might need to do a surgery. Similarly, for vaginal laxity, we may need to do a vaginal tightening through a surgery.
In a lot of cases after delivery, I'm talking about normal vaginal delivery, there are cases that women go through infections as well, right? Because of the stitches going wrong and all. So, how severe can it get and how do you treat that?
Right. So, see, typically when we do give episiotomy to the stitches that in the vagina that are given during the delivery is called as an episiotomy. Now, sometimes if it is a very large baby or a small pelvis or a traumatic delivery, or we need to use forceps or vacuum to deliver this child, there may be an extension of that episiotomy. It can even lead to incontinence of bowel function later, and or tears next to the urine, like paraurethral tears, which mean. So when there are very difficult vaginal deliveries, uh, with these, episiotomies, which might have a higher risk of getting infected. Of course, we put them on antibiotics. All of these women are put on antibiotics for a good 5 days. But yes, sometimes there may be some infection and then it can cause abscess over there. So, what we typically tell patients is to post when they are, while they are in the hospital, there is always, we always make sure that that area is cleaned and antiseptic measures are taken. But once they go home, we tell them that they can do sitz bath.
What is that?
Sitz bath is basically when you a bathtub where they can sit, a warm water bathtub, and they can just sit in that to reduce the inflammation and the swelling, and that really helps with pain as well. So this is something that we tell most of our patients, that you can have a sitz bath, which is uh, in a tub. You can put warm water and just sit in that for some time, maybe twice a day, which will help the swelling in that area.
PMOS now, which was early known as PCOS, it's kind of it's a most talked and used term when it comes to women. Somewhere it's associated with fertility also. If you have to explain me, if I ask what is PMOS or PCOS and what exactly going on inside a woman's body.
Right. So what was earlier known as PCOS, basically, polycystic ovarian syndrome. Now, what has I mean, it was always, I think, it was a misnomer. Women would associate it only with the ovarian cysts, but it was always a metabolic and endocrine disorder, actually.
So now PMOS, what's the full form? Polycystic.
Polyendocrine metabolic ovarian syndrome, basically.
Okay.
Yeah. So it involves the entire endocrine system. It involves metabolic issues, and of course the ovaries are at, they are also affected. And the main reason it does so is because of various hormonal imbalances, which can be insulin resistance. The main issue is insulin resistance, right? Insulin, which is supposed to reduce the blood glucose level in the body. The cells in that person's body might be resistant to the insulin that is being released, and hence the insulin is released at a higher rate, but it's not acting on the cells to reduce the blood sugar, and that causes a increased insulin in that girl. That can cause the ovarian hormones to become, basically disrupt the ovarian and the pituitary hormones. So there may be excessive male type of hormones in that girl. So androgen levels might increase, because of which she does not ovulate every cycle. Correct.
That's why, hence the period is
Periods don't
irregular.
come. Yeah. So basically the periods don't come every month as predicted. The menstrual cycle is irregular. There is irregular or infrequent ovulation, or sometimes anovulation. Matlab, there is no ovulation at all. And that's why conception is also almost impossible, because these patients are not ovulating. And of course, because of insulin resistance, they may be at a high risk for getting diabetes because of the high levels of androgens, which is testosterone, right? In these women, they have issues of hair which is growing on the face of the skin. I mean, the skin of the face, unwanted hair anywhere else on the body, thinning of hair, acne,
Yeah, chronic acne.
chronic acne. They, and typically because of insulin resistance, some of them may even have like a uh, velvety dark skin on the nape of the neck, like the neck behind the neck. They may have this typical, hyperpigmentation, velvety, thick skin. So it obviously causes body image issues. There may be associated obesity. And so it's a whole syndrome. In fact, because these women don't menstruate regularly, there is a chronic estrogen abundance, or the endometrium is basically the lining of the uterus, which gets there is constant estrogen which is uh, exposed to this endometrium, and that causes it to become very abnormally thick. And this is not to scare patients, but honestly, these women at a later age, like closer to menopause, they may even be at a higher risk for endometrial cancer. So, diabetes, obesity, blood pressure, which is hypertension, endometrial cancer, abnormal bleeding, heavy bleeding, no bleeding, irregular bleeding, and of course, fertility. So, PMOS is it's an entire spectrum. It can be mild in some patients, it can be very severe in some patients. We call them resistant PCOS. Matlab, we give them hormonal simple form of treatment to induce ovulation, but because their ovaries are so resistant, they don't respond to these simple kind of ovulation induction treatments like oral tablets or smaller doses of hormonal injections. They need higher dose, or they need to do IVF to, retrieve, to have eggs.
So was PMOS was always there? If it's always there, why it's so rapidly growing now?
I would say the lifestyle of young girls, exposure to certain endocrine stressors that we probably are not aware of. These are called as endocrine disruptors. So, even like your microplastics, things that we consume in our everyday life, right? Like processed food, and maybe even
Synthetic gym
synthet-
clothes, tight clothes.
absolutely, like clothes which may not, or even creams that we apply, or makeup that these girls may apply at a young age. And of course, exposure to, say, like their lifestyle is not very healthy. They don't sleep in time. They may not have an active lifestyle. They eat infrequent meals, or eat they overeat, they do crash diets. So I think the lifestyle that has changed over time has basically caused this rise in PMOS. And I think, as young people who are trying to give that give information in the right way, we should also make young mothers aware of the risks that their child is exposed to. If, say, there is a lot of sugar consumption at a younger age, there is an addiction for sugar foods, or like processed foods. So healthy eating, healthy active lifestyle, exercising, playing a sport, eating good nutritious food is something which has to be done very, very seriously. It has to be taken seriously by young parents.
These are the lifestyle changes can help in this condition. And you also said that there's a treatment for it. So tell me the treatment and tell me what are the lifestyle changes apart from this. Once you know that you have this condition, what can, with only lifestyle choices, can you reverse it or make it less severe?
Absolutely. Especially in young girls, the first thing that we tell them is to change their lifestyle a little bit. If they're obese, if they have a sedentary lifestyle, if they're sleeping at 3 a.m. and waking up at 12 p.m., we try to make those small changes. We try to make sure that they lose weight. So even if they lose about 5% of their body weight, they have a good, outcome of these issues. Of course, medicines are always available. They can be put on tablets to regularize the periods. They can be put on some supplements like myoinositol, and even medicines like metformin. Metformin is basically what we give for diabetic patients, but metformin is also a very, very commonly used drug for PCOS patients to help the insulin resistance. Because now, I mean, we are aware, we've always been aware that insulin resistance is a major issue, is the crux of the situation. So that needs to be tackled. So metformin helps with
So,
these
as a
girls.
doctor, when you say that PCOS is becoming, your PMOS is becoming more severe and now you need a medical attention, so what is the definition of when it becomes more severe?
Severity would be if they're just not having periods. Some of these girls, at even at 18, 20, they don't get more than 2 or 3 periods in a year.
It can start as early as 18 to 20.
It can start. So, see, when the girl starts menstruating at puberty, typically the first 2, 3 years, we see that the cycles are anyway irregular because, the hormonal pathway has not been developed in that sense. It takes about 2 years for it to regularize. So, we give that time. Post that, if there is any obvious signs of this girl having hirsutism, which is basically hair on the chin or on the body, unwanted hair, or severe acne or obesity, or any signs of insulin resistance, then we know that this girl has PCOS. And of course, there are lab tests that can tell us. We measure the androgen levels, we measure the insulin resistance and the blood sugars to know if there is PCOS, but a clinical diagnosis is really more accurate as well. So, and these girls may sometimes, in a year, they don't have more than 2 to 3 cycles. So, we know that this is severe and this needs treatment.
At what stage, like what kind of complication can it create in your fertility in future?
Yeah, so these basically they mostly require, some form of fertility treatment. Simple forms like ovulation induction, wherein we give some tablets just to start that folliculogenesis and to have 1 or 2 dominant follicles being formed, which we monitor by doing serial transvaginal ultrasounds. It's called a follicular scan, right? And we see whether this patient is ovulating with the medicines. If oral medicines don't work, then we need to give them hormonal injections, a smaller dose than what is given in
But they can still
IVF.
conceive with the
They
right
can,
treatment.
absolutely, they can conceive because, in fact, they have a very high number of eggs, larger in volume, and multiple cysts or ovarian follicles that we see on the periphery of the ovary. That is typically seen in PCOS patients. So, and they have a high AMH. So, these severe PCOS patients may have AMH of 11, 12, very high AMH. So, and then for them, if they don't conceive with simple forms of ovulation induction or just IUI, which is intrauterine insemination, then they can be offered IVF. So with IVF, typically we get good number of eggs, and then we freeze all the embryos that are formed, because these patients, we never do a fresh transfer. Fresh transfer meaning we don't transfer the embryos in that cycle in which we have stimulated or done the pickup, because they are at a risk of ovarian hyperstimulation. So, on one end of the spectrum, we have women who give us with poor ovarian reserve who have 4 to 5 eggs, and we are struggling to get good eggs. Whereas these PCOS patients, they will give us, I mean, we end up retrieving many eggs, but they're also at a risk of hyperstimulation. So, that needs to be taken care of. So, it's always a balance. Right. And yeah, so they do well. Honestly, PCOS patients do well with IVF. But having said that, they need to optimize their lifestyle, their weight.
And once they get pregnant, will there be any complication during pregnancy and after the babies, like anything to the baby?
So there might be a high risk of miscarriage in these patients. There may be a high risk of preterm deliveries, of low birth weight babies, hypertension, diabetes. These risks are slightly higher in PCOS patients because basically there is already a metabolic abnormality which has happened in that patient, and they are already insulin resistant to begin with. So during pregnancy, there might be a higher chance of getting diabetes.
And the baby will have any kind of complication genetically?
Genetically, no, but it puts the child at a risk of getting PCOS. If it's a female child, then definitely, history of mother having PCOS, the daughter will also have issues of obesity, PCOS, metabolic abnormalities. So it does run in families, unfortunately.
So what do you suggest to younger women or any women of any age to do, like what kind of practice or test or a doctor visit should be there in, should make it a habit so that to rule out all of this?
So definitely a pelvic ultrasound, an exam, like just visit your gynecologist, uh, get a pelvic ultrasound done to rule out, just to make sure that everything is normal. Uh, Hormonal tests can be done, like if their fertility, we've already spoken about what we need to do for fertility, but otherwise also other hormones can be checked. And regular visits are required. Pap smear can be done once the woman is sexually active. These things should not be missed out on. Even sonomammographies, like mammographies, either X-ray or sonographies, should be done because breast cancers can be picked up early. So screening, I think, is a must for all women.
Periodic screening.
Periodic screening.
What do you suggest? 3 months, 6 months, or yearly?
No. So see, Pap smear is every 3 years. Uh, Mammographies, unless there's a history, we start at about 40. After 40 is a good age to start. But yeah, you can get it done once after 35, and then yearly it can be repeated. Pelvic sonographies also, I would say every 2 years is if everything is normal. These things should be done. Periodic screening should be done.
Do women that usually comes to you, do they know that they have fibroids, or they
No,
are
they may not know. In fact, fibroids are the most common and sometimes asymptomatic issue pathologies that women might, be like they may just have a surprise on an ultrasound that they do or an examination that we do, and we are like, okay, you have a fibroid. You're not even aware of it, but that's a fact because so some fibroids may be symptomatic. They may cause heavy bleeding, abnormal bleeding, or extremely painful periods. And some fibroids, which are typically on the outside, like subserosal fibroids, they may just enlarge without the woman even realizing because they don't really give rise to a lot of symptoms. In fact, the last two fibroids that I have operated, one was, you will not believe it, one was 21 centimeters. And the patient was an educated girl and she had a uterus which was equivalent to a 7 months pregnancy, but she was just not aware. She thought she was gaining weight, and so it happens because they don't realize that there is something wrong with them, and they
so
won't
fibroids can happen only in uterus, or
fibroids are typically they are basically benign growths of the muscular layer of the uterus, and they start in the uterus. They may grow into the cavity of the uterus or sometimes on the outside. So, if they grow into the cavity of the uterus, they cause severe symptoms. Even a small 1 centimeter fibroid will cause heavy bleeding, abnormal bleeding, painful periods. But even a 7-8 centimeter fibroid, which is growing on the outside, may not cause any symptoms.
so the periodic checkups that you have suggested, the pelvic sonography,
Sonography
in
will-
that
Yes, it'll definitely rule out fibroids. And about 60-70% women have fibroids. Maybe 60%, yeah. So they're very common, but they may not always require treatment.
Okay, before we wrap up, we'll play a final round, myth or not. We'll ask a few statements, a few questions, and you can answer myth or not, or you can, if you want, you can explain it a little further.
So the first statement is, if you are fit, healthy, and take care of your body, your fertility won't decline significantly with age.
It's a myth.
Choosing a C-section is an easier recovery process for the mother compared to a natural delivery.
Again, a myth. Yes, it is a personal experience. It may, differ from woman to woman.
Bladder leakage after childbirth is permanent.
No, it's not permanent. It can be reversed. It can be very well treated.
Expensive creams and oils can completely erase or prevent pregnancy stretch marks.
No, that's a myth.
Postpartum vaginal rejuvenation is strictly an aesthetic trend with no functional or medical benefits.
Absolutely not. That field of gynecology, it's not just cosmetic or aesthetic. It is a lot more functional than what we realize. So
You should only proactively test your fertility if you suspect something is actively wrong with your body.
no, I would say do your preconceptional your fertility tests, even if you're absolutely normal. You may not know what's going on inside your body or what might come up as a surprise. So definitely needs to be done earlier.
Birth control pills damage fertility.
No, not at all. The birth control pills, they work to suppress ovulation for the time for which they are given.
Doesn't it going to affect period cycle?
Generally, what it does is it reduces the bleeding that happens and it reduces the pain. So that is a added benefit of the birth control pill. In fact, it is given for that medically for that indication when patients have a lot of heavy menstrual bleeding.
Since you're on this topic, if somebody takes emergency contraceptive pills on a regular basis because of maybe frequent partners or intercourse or multiple partners, will that affect fertility in the long run?
It doesn't affect fertility, but it's not as potent or as sure as what regular contraception is, right? So it should not basically, it is emergency after all. It can be taken one off and it can also cause the subsequent periods to become irregular. And there's always that constant fear in your mind that it has not worked, So emergency contraception is a great uh, uh, thing to have, but it should not be misused. It has to be used in an emergency situation. It's not a regular, it does not basically replace your regular contraception.
Last question, a healthy lifestyle guarantees fertility.
No, a healthy lifestyle unfortunately does not guarantee fertility. But again, to conclude, I would say healthy lifestyle can aid and improve your chances of getting pregnant, can make your pregnancy easy, can make your postpartum easy, right? So it has a lot of benefits, but it does not guarantee what genetic, uh, your age, basically what can't be reversed is how you age and the genetic uh, predetermined egg cell count that has been, already there. So it doesn't guarantee you fertility.
Thank you so much for this such a meaningful conversation. I can't thank you enough for making it here and having this conversation. We learned a lot from you, and
I mean, it was my pleasure. I really enjoyed having this conversation too because I think it's important that men and women both, are aware of everything that goes on.
Perfect. Thank you so much for taking out time. And
Yeah,
if there's
Thank
any questions that comes from the audience, we will certainly pass it on to you.
for
yeah.
sure. Yeah.
Thank you.
Thank you.
That was a great conversation, isn't it? I personally have learned a lot from her and this conversation. I'm sure you guys have learned too. If you have any question regarding this conversation, go ahead and ask in the comment below. Do not forget to like, share, and subscribe to our channel. Thank you for watching.